Hi, everyone. Again, thanks. Welcome to the final scheduled webinar for the value-based care for the FQHC program. Again, my name is James Pat. I'm the Chairman and CEO of Insight Health Systems. And again, we're very excited to be able to help sponsor this webinar series along with Ohio Association of Community Health Center, United Healthcare, and Cardinal Health. So hopefully most of you have been able to participate in the previous 4 or 5 weeks. Again, our goal here was really to identify key topics that were top of mind for the FQHCs in this transition to the value-based care. So we've covered quite a few topics: quality measurement and reporting, payment reform models, health information interoperability, patient engagement. And we're very excited again today to have Tracy Davidson with United Healthcare talk about value-based payment contracting. If any of you have missed any of the previous webinars, again, all of the presentations are available, and each of the webinars have been recorded as well. So you can actually download the video as well. So again, this is the 5th scheduled webinar as part of the series, but what we're also doing is we're adding a bonus webinar, which is scheduled for next Tuesday, August 18th, from 9 to 10. So if you can go ahead and mark your calendars for that. This is going to be exciting. It's going to be a different forum where this will actually be an interactive panel discussion. And again, Randy Runyon, myself, Tracy Davidson, and Dr. Ted Wimslow will all be participating on this. So in preparation for this, if any of you have any topics or questions that you want us to address as part of that panel discussion next Tuesday, please forward those over to us. Our contact information is available to you, and it will be at the end as well. But that's going to be an exciting webinar. We also may have another guest speaker or as well. So we look forward to having everyone join us on Tuesday, August 18th. And again, if you have any questions or topics you want us to address, please feel free to send those over to us beforehand. Okay, so as far as housekeeping, one of the things we're going to try now is actually, I know Tracy wants this to be as interactive as possible. So what we're going to do is we're going to unmute everyone's lines. And, you know, again, make this interactive. If you have questions, feel free to ask the questions. If you can do us a favor, and if you don't have a question, if you have the ability to mute your line so that, again, there isn't any background noise, that would be great. So I'm going to go ahead and unmute. Let's see if I can do this. Unmute everyone's lines, and everyone is available now to ask questions. And again, if you can do it courtesy to mute it. If you're not asking a question, unmute it. If you have a question, that would be perfect. Okay, and if you'd rather not ask it yourself and just chat the question, you can chat that directly to me, James Pat. So on the bottom right-hand corner, there's a box. You can just type in your question, send it to James Pat, and I'll be sure to ask a question at the end as well. And hopefully we'll try to allot 10 minutes or so, 10 to 15 minutes to answer any questions. So again, we're very excited to have Tracy Davidson be our guest speaker today. A little bit about Tracy. Tracy Davidson is the CEO of United Healthcare Community Plan of Ohio, the Medicaid division of United Healthcare within the United Healthcare Group. Tracy became the CEO of the health plan in 2011, and prior to this role, Tracy served as the Vice President of Strategic Improvement Initiatives for the Quality and Performance Division in the Medicare business within United Healthcare. Tracy has a long and diverse history with United Healthcare, including more than 13 years serving in leadership positions in network management, compliance, and operations. In her current role, she has oversight of a complex multi-product statewide health plan. And under Tracy's leadership, United Healthcare was awarded its first integrated Medicare-Medicaid program contract to service members who are eligible for both Medicare and Medicaid. Before joining United Healthcare, Tracy held leadership positions at hospital, ancillary, and rehabilitation settings. She's a practicing speech pathologist and a past certified case manager. Tracy is also a published author, having written articles for journals Neurology, Continuing Care magazine, and a book chapter for practicing speech-language pathologists. She's also a frequently requested presenter at state, regional, and national forums covering a variety of health industry topics. So again, we're very excited to have Tracy speaking for us today. Tracy earned a Bachelor of Science degree and Master of Science degree in Speech-Language Pathology from Bowling Green University. She currently serves as a committee chair for the March of Dimes Nurse of the Year initiative. She's also the government program chair for the Ohio Association of Health Plans. She's a member of Circle of Red through the American Heart Association, Healthcare Businesswomen's Association, a board member of Physicians Care Connection, and a board member to the March of Dimes. I don't know how you find all the time, Tracy, but again, very glad to have you, and I'm going to go ahead and pass controls over to Tracy.
Fantastic. Good morning, everybody. We are going to try to stay on task here with me getting the ball and doing all the technical work, and it should be coming, and I think it is, and yep, there it is. So before we get started, first, I just wanted to say what a pleasure it is to be here this morning. It is a great opportunity as well as honor for me to be able to be here this week during National Health Center Week, and I wanted to extend my very sincere gratitude and appreciation for all of the work that all of you are doing in the communities across Ohio, extending access, providing care and service to those who really need your care and service. I'm excited because we've got here within United Healthcare Community Plan well over 20 to close to 30 events this week scheduled across the state celebrating National Health Center Week, and I couldn't be more proud to be a partner with many of you in our initiatives to expand and extend coverage to folks. So simply stated, you guys are really important to us, and I'm delighted to be here today. So when you guys read my bio this morning, it makes me tired to think about all the stuff we have been up to within Ohio, as well as the fact that I'm the mom of 3 and the wife of a Columbus police officer. So my greatest gift are my 3 kids, and 2 of them are getting ready to head off to college in the next 2 weeks, one for her first year, one for her senior year, and then I have an 8th grader heading off to middle school tomorrow morning because we start early here in Central Ohio. So my greatest gift and my greatest achievement are those 3, and so thanks for letting me share some of my background with you. So this is what we're going to talk about today. We're going to start with what's driving reform and specifically what's going on in Ohio that's getting us what we're talking about this week. We're going to talk a little bit about United Healthcare, and the reason we're going to do that is not as a promotional, but really as a base of the basics of what value-based contracting is. My experience, of course, is within United, but a lot of the tenets of how value-based contracting works we have experience with, and they're applicable across multiple different payer types and provider types. And then we're going to actually run through an example of an opportunity that we could think through. It is definitely an example. We do not have any of the accountable care shared savings models here in the state of Ohio that I'm going to go through today, but we do have a couple across the country, and so we might be able to pull some of that information into Ohio and do some work together in the next coming years so that we can really put this into practice. So let's do a little bit of a tutorial and talk about Ohio and kind of behind the scenes what's been going on around here. Most of this you guys are very, very familiar with, but I thought it set kind of the stage. And I'm going to try something a little different. I'm going to share my screen because I'm going to go out to the internet and we're going to find a particular website that I'm not sure if everybody has seen. And what you should be seeing on my screen is the Ohio Office of Health Transformation's website. And the reason this is particularly important to our conversation today is it really sets the stage for why we're here and some of the work efforts that are going on across the state on reform. And I wanted to call your attention to some resources that you may or may not have seen, but that really begin to put the foundation together about what we're all up to. So let's do the strategic framework first. This particular document, the Innovation Plan, is really the roadmap of what the state is up to in the way of modernizing Medicaid, streamlining health and human services, and then particularly looking at paying for value. And the reason I like this simple page is that it really begins to put together what the state is trying to do, and I'm not even talking about the Ohio Department of Medicaid, but actually the larger infrastructure about reform and trying to begin to transform how we pay for things. And then we can talk specifically about how this fits into the Medicaid business and then FQHC. So if we look at this last column, this really begins to put into practice what's happening across the state of Ohio in the way of payment reform. And of particular interest is the current work team down here at the bottom, where we are actually and actively across the private sector as well as the state government sector looking at how we can innovate payment and how we can do 5 specific things. One is pay for value, of course, instead of volume. Provide access to more medical homes, which many of you are serving that need for today. Using episode-based payment, and we'll talk a little bit about that and what that means in a little bit. Coordinating health sector workforce and training programs, a little bit different, but this is all about the jumping off point about getting individuals back to work, and how does the innovation plan deal with that. Coordinating health information technology infrastructure, and then aligning our population health planning and priorities. So there are work teams all across the state that are addressing all of these areas of reform, and they point back to paying for value. So how do we engage providers and payers in the conversation about having clear expectations for the triple aim: better health, better care, and lower cost? Right? And that sets the stage for all of the policy priorities that are coming into play for the state, all of the work efforts that are underway to help advance this particular item. And the problem is really what the background's all about. We spend more per person in the state of Ohio in all but 17 states. So that means that we are spending a whole lot of money on health care, but we are 37th in our overall health outcomes across all of our state regions and counties, et cetera, so all of our population. So if we think about the fact that we are spending more per person but getting less for the outcome, that's a real initiative to do some change controls. And the policy priorities that are really supporting that agenda are paying for value instead of volume, making healthcare price and quality information transparent. So probably as employees of a variety of different agencies and organizations, you're beginning to see in your own healthcare experience plans like UnitedHealthcare or others giving you additional information about quality of the providers that you're choosing, as well as how much it's going to cost you out of pocket and how those two align. We are beginning to see requirements through the Ohio Department of Insurance requiring us to be able to provide that type of information to consumers. In the state Medicaid contract, for those of us who are in the Medicaid health plan space, we are also starting next year going to be required to promote quality standings of our provider community. And we're going to start with physicians, but that is kind of the global entity here, is giving information to people to make choices to help drive down some of the costs of care. And then this infrastructure piece, which is really what I think James probably talked about a few weeks ago, getting the right information in the right place at the right time. So the reason I wanted to start on the agenda with the payment reform in Ohio and kind of what's driving reform and what are we up to and why was specifically this column on pay for value. And I wanted to give you these tools because I think they're really important to know what's out there and to begin to use this particular website to keep up to date and informed. You'll see down here at the bottom, pay for value. There are a tremendous amount of materials that are posted very frequently and updated around what this all means. And so let's go out there just to show you what it looks like. So what this is about is, again, I already mentioned this before, that we are 37th in health outcomes. We are, this says 30, so it must have been updated. I think that might be a typo, quite frankly. But anyhow, there are a lot of states that are ahead of us in their outcomes. And if we can't get people healthy, that means we can't get people to work. And so there's a real combination of workforce development as well as how do we begin to shift the go to the doctor, get a service, still stay sick concept, and really look at how do we go to a provider, get the right care at the right time for the right price, and actually improve the health and well-being of that individual. So there's some interesting materials under here, and again, I'm not going to go through all this, but I wanted to show you what was here. The two big ones that we are focused on right now as an industry are around patient-centered medical homes and episode payments. Episode-based payments are really the background of how we transform how care is paid for. And what we're starting with is the hospitals, and everybody's familiar with DRGs, right? The historical component of DRGs is that services are bundled and you get a certain dollar value based on weights of where you are in a region or in a state or in the nation, across the nation, what your teaching rates are, et cetera, and you get kind of a base rate, and then different diagnoses categorized to different payment schemes. In episode-based payment, it's a little bit different. In episode payment, we still do that work, and we still provide this care and services, except there's a retrospective review of the outcomes of the individuals who received, let's say, a hip replacement. And then there's a lot of modeling that's done that goes back to the norms of what you would expect in that community for that specific hospital. And if there are outliers, to the plus or to the minus, either one, so we're not near the median, dollars are actually either taken back or more dollars are given. So it's a retrospective review. And right now we are rolling out 7 episodes across the state of Ohio. But over the next couple of years, the goal and objective is to have over 56 to 60 different episodes that are commonly done, that we are actually looking across all of our hospital systems and all of our provider partners. And I don't mean we, I'm saying the state is actually changing the way they're going to pay for care, and then the health plans, the insurance industry, whether that's through the private sector or through Medicaid health plans, will then be working with the hospitals in the state to look at a quality shift and identifying where dollars should be either taken back because the outcomes weren't as intended, or actually different additional dollars provided for services that have been rendered even better than expected. So I'm not going to go too far into any of that, but I wanted to give you the background about what it was about so that as we start talking about the kind of pillars of value-based contracting, you can kind of see where some of these ideas are generating from, and that there really is a transformation going on around how payment is rendered in different ways. The next initiative within the state viewpoint is all around patient-centered medical home. And that is a lot of the work, I think, that will begin to touch our FQHC community, and it's just becoming live. The work groups are just getting started, and we will be looking at what does it mean to have over 80% of Ohioans, that's the goal, attributed to a primary-centered medical home, meaning that there is an engaged, outcome-oriented primary care relationship for 80% of Ohioans. And that's a pretty lofty goal. But I believe that we can actually get there, and that is under the guiding principles. This will be the last one I show you out here. The guiding principles page really provides the backbone to what the Office of Health Transformation is up to in the state of Ohio, and really what forms the foundation of work. So some of their rules are the work that they do is market-based. They're promoting personal responsibility. The work that has to be done has to be evidence-based, transparent, which we've already talked about, value, which is pay for what works to improve and maintain health and stop paying for things that don't, really focusing and investing in primary care, looking at where we can begin to shift some population dynamics and improve our chronic diseases, invest and enable in long-term care so that our seniors and people with disabilities can stay in place and not have to transition into a higher cost setting, and then innovation. How do we constantly look at ways that we improve this paradigm and demonstrate not only here, but also nationally why Ohio is a great place to live, work, and play. And again, I think that these kind of form a really nice backdrop to what we're going to jump back into now. And let's see if I can do this. There we go. All right, so now we've talked a little bit about Ohio behind the scenes. The 3 things they're trying to accommodate for are quality, managing costs, and making sure that we have great access for all the expansion of coverage that's gone on over the last year, year and a half. So before I jump forward, we doing okay?
Yep.
Questions? Okay. Any, what do folks think about that particular web page or website? Like I said, I think I heard one person say they've navigated it before. Folks find that might be a useful resource. I can make sure that I follow up with the link so that it's easily accessible.
Tracy, the Healthcare Transformation website is really helpful, and I'm glad that you actually are using the same one. One of the questions that many FQHCs have is around patients in our medical home is a great idea. How do we tie incentives to it? So we're still getting paid on a fee-for-service number of patients we're seeing, and we all want to move to higher quality. Any thoughts on how we can get the incentives aligned with where we want to go?
Yeah, and actually we're going to talk a lot about that. So that's a great segue into kind of where we're going next in our conversation. And if you hold that, I think we'll have a few more answers to that question throughout the rest of the presentation. Great. All right, so I'm going to do a little commercial here, but again, it's not a promotional commercial. It's more about giving you some information about why we have some expertise in this area of engagement on value-based contracting. And we are a Fortune 15 company, and really what that means is we employ a lot of people. UnitedHealth Group has over 170,000 employees, but that's 28,000 of those are clinicians and actual physicians that we work with, and we actually manage or have oversight and insure over 85 million people in the United States. And the reason that's important is because we have a lot of tools in the toolbox and a lot of things that we've tried that work and things that don't work. So to get to a little bit of that question about how do we begin to do this work more effectively and align incentives, we're certainly not perfect, and we do make mistakes, but we have a lot of trial and error in our toolbox to help us. And here in Ohio, we have about 2,500 employees, and that's across all of our lines of business, as well as we serve about 2 million Ohioans. So that's across the Medicaid space, the Medicare Advantage space, the commercial space. All the state employees have access to UnitedHealthcare insurance. And again, we can try a variety of different value-based contracting constructs in those different environments. So right now, the Medicaid office in the state of Ohio, not the office, but the Ohio Department of Medicaid, is requiring managed Medicaid plans, so myself, as well as Molina, CareSource, Paramount Advantage, and Buckeye, to have 50% of our medical spend invested in value-based contracts by the year 2020. So let me back up a bit, okay? We have a contract with the state of Ohio, all 5 of the health plans. This is important, obviously, for all of you guys to understand, because we then are incented, we have to, it's a requirement, have 50% of our medical spend in some type of a value-based arrangement with our provider community. So the opportunity is ripe for this conversation because all of us have to be able to figure out how we work together collectively to begin to put the majority of our spend, our medical spend, into some type of a value-based arrangement. The private sector, so my commercial counterparts, can't really be required to do that. Employers can require it, but they're not really governed by a state agency. And so that's kind of a voluntary effort. But the Medicaid space tends to be quite the research base, and we have the opportunity to trial a lot of activities and a lot of things. So aligning incentives and starting to look at high quality and coordinated care, evidence-based care, primary center medical homes, we are really encouraged and have to, at this point, be able to demonstrate how year over year we're improving in that space. So let's go to this next one. So what does that mean? So that's a lot of words I've been saying, and what does this actually mean for the conversation today? So there's a real shift towards collaboration, as everyone knows, and really thinking about outcome-based payment, and how do we do it? What is it all about? So it's about paying for value. It's about transforming the delivery system so that we're sharing information more broadly and aligning incentives, which is kind of the question that came up just a few minutes ago. And how does this work? All right, let's get to the next slide. This is the one slide that I'll probably spend the most amount of time on, and with really me saying the least amount. And that's kind of a funny statement, but the way that this is stacked is the opportunity for folks to see where providers are in their tolerance for risk. My goal as a provider, as a payer, is to not ram down anybody's throat my way of doing things. we need to be able to, when we talk about collaboration and partnership, figure out where on the stair step our providers are in their ability to, infrastructure-wise, accept risk, align incentives, look at transparency. And so what you see on the stair step is the very bottom, fee-for-service. There are going to be some providers that fee-for-service is the thing that they do. Perhaps maybe that's ancillary, maybe that's a lab, maybe that's something that is more of a genuine service. But then we move up the chain here and start looking at three different, in the way that United views things, three different ways of the accountability continuum. So we have performance-based programs, service line programs, and accountable care programs. And what those are really looking at is that we don't think that all providers should all be at the top. Not all providers are going to be able or want to even be in a capitation or a full risk arrangement. Some are going to be wanting to do something more on a basic quality model, being incented to do certain things that we can easily count and that we can look at performance. Some are going to be somewhere in the middle. And the service line one, this red document or the red pillar, just as an FYI, is really about things like centers of excellence, like transplant centers of excellence, cancer centers of excellence. This one doesn't really apply to our FQHC space so much, but to the right and to the left certainly does. And this is where I think we've got some real opportunities to do some unique work, and how does this look and feel. So performance-based programs, those that are in green, are metrics-focused. They're really looking at primary care physicians, as well as large physician groups, some ancillary providers, and some hospitals. And we're looking at some basics like HEDIS measures, and maybe some things like hospital readmissions, hospital-acquired conditions, potentially avoidable hospitalizations, some basic quality measures. The service line programs we just talked about, most of those are kind of bundled. They're oncology centers, they're they're orthopedic centers, or they're transplant centers. There's kind of a service line excellence that we do some unique different things with. And then there's this whole gamut of accountable care programs. And this is really where we're starting to advance population health and using our population-based metrics to drive value. So these are programs around capitation, capitation plus performance-based contracting, shared savings, shared risk, and some all the way up to accountable care organizations. And I'm not going to get into a whole lot to ACOs today, but if you've seen one ACO, you've seen one ACO. For those of you who may remember Patrick Beatty, who was the policy lead at ODM for a number of years before he moved into the ED role over at the AIDS Task Force, he used to say ACOs are like unicorns. If you've ever seen one, it'd be a mystery, because they all look and feel a little bit different. So it's really how you define things about what an accountable care organization actually does. So when I look at this stair step, again, just to talk about weight here, we have in one way, shape, or another over 600 hospitals, 80,000 physicians, and 1,200 medical groups that are in some dimension of this stair step. And about 60, maybe close to 80 at this point, billion dollars across United Health Group are in some type of value-based arrangement. And so we've gotten pretty good at some of these types of programs. Out west tends to be a little bit more unique just because they've been doing up here, the orange section, a little bit longer. And where I see us here in Ohio, specifically United Healthcare, I can't speak to the other health plans on the Medicaid side, but I would tell you that we have a couple up here. But the majority of our work efforts these days, when we're talking about transforming and giving people skills, and I don't mean people, but giving the toolkits and the dashboards and the summaries and how we work together, how do we align incentives, much of that work is coming down in the green zone.
That's great, Tracy. I had a follow-up on that.
Sure.
So as we try to drive everything toward the value-based payments, 80–90% of what affects a person's health is what we're now calling social determinants of health.
Mm-hmm.
So if what we do in the clinic is 10 to 20%, and that's where our focus is, and that's where our billing codes are, how do we find some way of accommodating these, especially as we're driving population health management, where I can see where a population in my FQHC needs maybe more transportation, needs more fresh fruit, needs things that we often overlook, but those are the social determinants of health that are actually driving their care and their health. So rather than wait until they get to my clinic and I've got to address them at that point, how can we all work together so that we're getting the social determinants of health addressed as well?
Perfect question, and you are asking me great leadway questions into my next example, because you're exactly right. The things that the FQHC or many of our PCMHs are doing are in the clinic and then helping to get in ahead of the social determinant issues that are bringing people in there to begin with, right? And you need to be able to spend your capital, and I don't mean the capital building fund, I mean your resources, wisely on the medical expenses, and then help partner around the community for the other kinds of social determinant issues that are impacting the people that you're seeing on a daily basis. And so how do we bring you more value to the dollars that you are providing care for, so that you can share and then reinvest in some of that as well? And when I say you, I'm talking about more about the whole partnership concept or collaborative efforts among how we begin to get deeper into a community. Infant mortality is a great conversation that we could have on another day around how do we really all drive towards those kinds of solutions. Quick sidebar before I jump into this part of the presentation. I've been changing my verbiage when I'm talking about infant mortality, and I wish I could take credit for it, but the Cincinnati market, and I don't know if shout out to anybody from Cincinnati who's on the phone today, all their work efforts around infant mortality, they have really changed the conversation, and they're talking about infant vitality, and I love the paradigm shift. If we can start talking about how we improve the health of our infants and how we improve the vitality of our mothers and our maternal health programs and services, it's a much different conversation than talking about mortality. So applause out to the Cincinnati groups who have changed the conversation, and I think we all need to infuse infant vitality versus infant mortality. But I apologize for the brief commercial. But that's exactly what we're trying to figure out, is how do we get in and align and drive additional resources. Right now we're all trying to, and I'm talking specifically FQHCs, you have to see so many people and do so many things that your money is finite, right? It's really directed toward the day-to-day operations of a clinic. But let's open that box a little bit and talk about if we could start changing the dynamics about fee-for-service. This is an example, so let me back up a bit. This is an example of an accountable care shared savings model that we have with probably 5 or 6 of our FQHCs in Kansas. And I am trying to bring this kind of information into Ohio as well and figure out how we can do this work more successfully in Ohio as well. But it's taking fee-for-service as kind of the platform. We're all good at it. We know how to do it. Adding a clinical integration payment. So to the question you just asked me, how do we begin to get kind of around the social determinant issue? I'll talk about what that clinical integration PMPM is in a second. Look at shared savings. So if we're both moving in the right direction, so if we're both addressing the ER avoidance, the education campaigns, the access issues that we have today, and we achieve some scale in that, we'll share those savings and give those back into the FQHC, where you then can use that monies to do other kinds of investments, other kinds of work, expand services, hours, whatever the it might be. And that is how the accountable care shared savings model works. So you take the provider's fee-for-service reimbursement, add in a clinical integration payment, which we'll talk about in just a second, some shared savings opportunities, and then you wrap it around. The foundation of it is all the HEDIS and quality metrics that we are all trying to really improve the health outcomes of the people that we are serving. And you wrap that all up into a pretty package, and it ends up being a very robust program. So let's talk about what that means. So clinical integration, this is just an example again of the types of outcomes that we could be incenting and that we could be all driving towards. Same-day access to care, inpatient care transitions, visit care or emergency room transitions, and maybe some high-risk patient populations. And you'll see across the domains here, what does it mean, how will we validate it, and what does compliance look like? So if you look at the very last column, it says at least 50% of the UnitedHealthcare patients that call in can be seen on the same day. So what that means is we're looking at same-day availability. And if we can achieve that particular metric, then it's kind of a check in the box. So we all have to work to figure out what that means. So does that mean you need a nurse manager or a case manager or a navigator in your building to do some of this work? Maybe we'll pay for that. Or maybe we'll pay you some type of integration payment where you can then figure out what you need to be able to achieve these metrics. Second one, at least 70% of patients discharged are seen with their PCP within seven days. Third, 60% of the patients discharged from the ED are seen by their PCP within 7 days. And then last but not least, at least 80% of patients in some type of a high-risk cohort are seen and have an active care plan in a period of time. And again, these are just examples, but you begin to see how we're really starting to get to the daily work efforts of specificity. How do you track these? How do you report on them? How would you get paid for them and prove that you did these things? And that's where all the transparency, the integration with EMR and or some other type of an IT solution help us to care plan in a more meaningful way, track outcomes, et cetera. And then when we talk about quality, we talked about that bottom foundation of how this whole accountable care shared saving model works. This is an example of the types of metrics, and HEDIS is the kind of industry standard where there's a lot of evaluation done at the national level of benchmarking about where certain cohorts and certain types of services should be achieved within a certain market or geography. So let's say adolescent well care. It's one that we struggle with here in the state of Ohio quite a bit across all of the health plans today in the Medicaid space is getting kids in for their adolescent well visits. But if we came up with a baseline for your facility, let's say Lower Lights, and I'm just making those up, guys, so has only 10% of the people assigned to them that are in the adolescent category are seeing their PCP on an annual basis. So let's move them to 50%. How do we get it to 50? What do we do differently? What outreach do we do? How do we get into the communities? How do we work together to get to schools? What is it? What's the magic bullet that brings in what should be benchmarked so that you, the FQHCs, can benefit from sharing in the savings of anything that you would do to get more kids in for adolescent well care? By the way, that was a completely made-up example. Off the top of my head, I have no idea where some of our providers are in their benchmarks. So now this puts it into meaningful kind of dollars. And so when we talk about benchmarking and contracting and transparency and clinical integration and all that stuff, the rubber meets the road, and what does that mean in the way of dollars and transforming healthcare, and how do we share information, and what are we doing to be able to tap into additional dollars for the provider community. So we have a BCR. BCR is your kind of cost ratio of what it costs you to take care of somebody. So if out of $1, if you look at this baseline BCR, if it's 91%, if you're spending 91, almost 92 cents out of every dollar on healthcare for the people that you're serving, there's not a whole lot left over to do other things. Other food programs, other grocery store programs, other healthy activity programs, other diabetes prevention programs. There's not a lot of money left over if your BCR is running that high. But what about if we could decrease it by a bit? What if we could figure out a different way to get people in more frequently, to decrease the load of work and burden of the types of services that are rendered so that we decrease that BCR in some way, shape, or form, and we change your target to get down to 86? A lot more money in your pocket, right, to begin to do work. Then we look at the shared savings bonus. If you can bring it down to that, if you can bring it down 4 points, 5 points, 6 points, we begin to look at how do we share the savings that are accrued from the work you're doing, from the work I'm doing, and share those dollars back to the FQHC so that at the end of the day, you have more money in your pocket to do other things that you want to do, both for the community and for your FQHC at large. And then finally, so I want to take some questions, there's this clinical integration payment. and this is fairly new game. It's fairly new for me, and I'm not an expert on this one. Although I came out of the contracting and network division, a lot of these programs have come up recently, and so I'm learning this one as well. But the idea here is that there are specific clinical programs and services that we need to happen, we both collectively. We need to look at same-day access to care. We talked about that on the first example slide. Inpatient care transitions, meaning are the people in the right level of care, and if they are, do they get to their primary care physician or primary care home within a reasonable time frame after they've left. Emergency visit transitions, you name it, we could actually define what would go into this particular summation of dollars. But really what it is that we would pay for certain clinical services that might be rendered by a nurse or a navigator or someone else in your facility, and that PMPM is dollars in your pocket to do work with that helps drive some of those BCR declines as well as the quality improvements. And it's kind of cash in your pocket. We're paying for every member that's part of your panel. So if you have 5,000 United Healthcare consumers that are assigned to your FQHC, you would receive a per member per month fee. We would give you money based off that patient population that we would almost invest in the FQHC to do your work differently, to add staff, whatever it was, to achieve different outcomes, to really target certain heinous measures, or to really look at the population around the facility to figure out what else we should be doing differently to improve the health and well-being of the community. So finally, let's talk about so how do we share all this information? Again, this is a sample, and it's taking all the information we just talked about, BCR projections, benchmarks, quality metrics, clinical integration activities, and creating a reporting tool where we can be transparent with each other about how you're doing, how we're overseeing how you're doing, how we're doing, how are we paying you, how are you. So it's really all about a collaborative partnership relationship and transforming our business model as well as transforming the way healthcare is paid for, because as you can see here, it's not just person comes in, person sees a physician for an H&P, person gets a lab, gets an x-ray, gets a pharmacy, gets a whatever, and leave, go to the ER gets paid, they come back again. It's really more about total cost of care and understanding how each point in the continuum has an outcome associated with it, and then where do we get upstream so that we can begin to either decrease those touch points or improve the outcomes when the touch points occur. So I'm going to stop because I know we've got about 10 minutes left for questions. And the other thing I wanted you to know that's in the deck once it gets posted is the United Healthcare Community Plan testified in front of the House during the House Finance Subcommittee in March about payment reform. And specifically, we talked about value-based contracting, some of our experience around the country, as well as really the paradigm shift in how do we begin to think differently and how we transform healthcare in the industry overall. And it was a position from the Ohio Association of Health Plans. It wasn't just United Healthcare's position. And I wanted to make sure you had a copy of that testimony because it really provides some of the backdrop to the discussion that we've had today, and then point you back again to the Ohio Office of Health Transformation and some of the basic tenets and principles that they're driving towards. It kind of all comes together, and I thought it might be a helpful piece of literature to have in front of you. So let's jump back, and oops, I thought I had a question slide in here. There we go. So let's open it up for some questions, and again, if I can't answer them today, I'm happy to put them on a parking lot list and get them prepared for next week's panel conversation.
Tracy, I love the slides at the end there with all the scorecards and such. So anything that we can do to measure and demonstrate value, fantastic. Much of what we've done in the past has been based on claims data. Are you suggesting now that we're going to integrate some of our clinical data from our EHRs and so on into a monthly scorecard?
Yes. So if I could do it tomorrow, I would do it tomorrow, because claims data is retrospective. I would really rather have some real-time engagement with my collaborative partners. And so, again, guys, some of this is, and I don't want to use pie in the sky, but some of it is aspirational. We know that we're not here yet, right? We've got to do more, whether it's CliniSync, whether it's HealthBridge, whether it's using some of the resources that James has presented with Insight and some of those modules of how we connect information. But for us to truly impact care, we need to have almost a registry, right? And this starts with even the hospital, understanding when our consumers hit the ER. For all of us, knowing when we need to do outreach so that we can in real time get them in to a 7-day follow-up, understanding when people are accessing care outside of their primary care home. That requires a level of integration and transparency that we are at the very beginning of, that I would like to really think differently about how do we advance that quickly and how do we do it right so that we can manage people. And I've got my care management hat on. I think you saw in my bio. I'm a certified case manager, and so I am passionate about life care planning and really understanding the trajectory of care of an individual. And you can't intervene if I'm waiting on a claim analysis that happened 6 months ago.
Wow. It's almost like you're inside my mind. So this is exactly what I want to hear. But but we still have some, I hate to call it, grunt work that we can't get done. So simple things about getting our data out of our existing EHRs. There's a fee for that. There's a roadblock for this. There's a HIPAA question around that. Do UHC or maybe all the Medicaid providers plan on doing something with the state of Ohio so that there's a pool of resources like when we first implemented EHRs, so that we can get some help on getting our data out of some of these systems and addressing some of the compliance issues?
Absolutely. And so when you went back to, and I think it was on the Health Transformation Innovation Plan, there is a very substantial objective around coordinating health information technology and infrastructure. And I mentioned, too, Cincinnati, kind of Dayton, kind of the southern part of the state is using HealthBridge, where other parts of the state are using CliniSync. And James, I know that you're out there. If there's other, tools in the toolbox here, you can help me for describing some of this work, and maybe it's a conversation for next week. These are infrastructure technology solutions for how do we connect communities of healthcare and services around care planning and care information, I should say, that are really, hospitals have gotten pretty good. If you're in a health system, so I'm going to pick on Cleveland Clinic, right? If you're in a health system, most of their system partners are connected. It's when you start getting outside of those that we have to share detail and information in real time that becomes the problem. And so all of the new innovations and tools and technologies that are kind of the underpinnings of that work are beginning to pop. And I think the time is ripe. And if we can get it right in a few places, then we can expand it.
Tracy, there's a few questions that were chatted here that I'll ask. Several of them really are the same question. It's everything sounds great. It's a very big picture. How do we get started, and what kind of resources are available to help plan how we get from here to there?
Yep, that's a fantastic question. I'm going to talk about it from United Healthcare's perspective. If you have conversations with your other health plan partners, you can use some of my words. It's fine. They won't be a bit surprised. But one of the places that we've started, and we have 4 accountable care communities with 4 federally qualified healthcare centers in Ohio today for United Healthcare. We have 4 more planned yet this year. So hopefully by the end of 2015, we'll have about 8 up and running, all in different levels of that first part of the stair step. It does take effort and energy and resources. Because it's very new, it's not a template, and every single center is a little bit unique, and so it takes some time. So we are working with Randy. We are looking at, through the association, are there different ways to scale this type of work? But I will tell you, it is a labor of love, and it's not simple. So you're right. Thank you for calling me out on the big picture view. It is. It is definitely an enterprise kind of big picture view, but practically and tactically it works. And we have to be able to dive in and start and get organized around what it means. We are struggling a little bit on the technology side as well with our FQHC partners, and so it's an area of opportunity. And then the second thing I would say is volume. So one of the things that helps us to help you is when we have volume of patients. So it's just like when I have a PCP who only has 3 or 4 of my members. It's hard to change a business model or practice or to be able to incent a physician to remember out of his, panel of 10,000 people that he has to just do something different for 3 or 4. So where we started strategically is where my populace is. So where I've got a large grouping of members that are accessing a certain place. And so whether that's an FQHC or whether that's a primary care practice or whatever that it is, strategically we've had to say, let's start with where we have a large population of consumers that are accessing care in that place and figure out how we do it right. And then we can begin to dabble in what tenets of that can we take to apply to smaller regions, to smaller markets, to smaller centers, and then how do we work collectively together to get larger volumes of panel and patients and consumers to the health centers that want to do this work. Does that make sense?
Yeah, no, that's excellent. And I have a feeling that next week for the panel discussion, I think there's going to be a lot more questions around specific, tactical plans to help an FQHC plan to take one baby step at a time, because again, it is a journey that they have to move towards, and it's going to continue to evolve as we go. And I think that a lot of folks we're talking to is they have to take baby steps. What's the first thing I can do to move forward? Then what's the second thing that we can do to move forward?
Yeah, I think that's a really great point. And so let me do a little homework on my side about just that. Are there some meaningful measures that the FQHC community can take to begin to either grease the skids, to jump in with both feet, right, or to dip your toe in the water? Kind of what are some practical things to get things started? And let's see if I can come up with some of those that we can share next week.
Great. We have time. Does anyone have any last questions for Tracy? Okay. Tracy, everything was great today. The information that you shared is wonderful. So thanks again for taking the time with us. And again, it was just some great information. If anyone, again, has any other questions, feel free to email either Tracy directly or me, and we'll make sure that we cover it either in an email back to you or cover it in the panel discussion next week. Again, thanks for your time. I also want to thank all the sponsors again for the webinar series: Ohio Association of Community Health Centers, Cardinal Health, again United Healthcare Group. And I did want to again remind everyone that we do have a panel discussion scheduled for next Tuesday from 9 to 10. Again, all the presenters are going to be available to answer any questions that you have. I'd like to thank everyone for taking the time this morning. Tracy, again, thank you so much for taking the time, and we look forward to seeing everyone here next Tuesday.